डैंड्रफ की वजह से भी हेयर फॉल होता है? जी बिल्कुल.
Hello guys, am I audible and visible? Am I live? If so, just give me a heads up. Okay, I think I'm live. Okay, thank you everyone. So let's start and learn a little bit more things about pathology for the upcoming INI-CET. So how many of you guys are seriously preparing for INI-CET? So that's my first question. Quite a few are. And I hope you must have had a little bit of break after your NEET exam, or you went. Okay, good evening, Amit. Good evening, Atmiyada. Good evening, Vishta. Or you must have directly went ahead continuously studying for INICET, whatever it is. We are going to learn a little bit more information about INICET. I'll be covering two selected topics from the previous year question paper. I cannot cover everything here. I'll go with one topic and let's make sure that we'll cover entirely around that topic. Fine. Hello Dhruv. Hello Rajendra. Good evening. Fine. I mission complete. Come soon as a NEET PG aspirant. Fine. Okay, now let's go on and I since it's a very all these are PYQs. I want your answer first, then definitely we'll go to the discussion related to that. Good evening, Abhishek. So without any undue delay, before going to the class per se, if you look at the INICET, the pattern is not stable. If you've been giving the last two INICET, what happens is one exam the general path becomes more, one exam the systemic path becomes more, one exam the hemat becomes more. The reason for this variation is when INICET was formed, one of the predominant one exam will be given, the onus will be taken by AIMS, one exam the onus will be taken by JIBMA, one exam the onus will be taken by PGH. So based on that, we have a subtle variation in the exam pattern. But having said that, there's always a constant weight on blood transfusion hematology and a little bit of genomics in INICET. Everything, any topic you take, a little bit of higher end will be asked. So be prepared for that after you complete everything normal for us, right? Good evening, everyone. And with that note, let's start the first question. I just want you guys to give the answer. I'll just move myself so that you can see the image, though I am sure that you won't require the image for this. I'll mute myself for a few seconds, comment on the answer. Whatever comes to your mind. I'll read through the question. A patient was admitted with loose stools, abdomen pain, upper GA shows some image, and this is the biopsy image from the upper GA. Identify the pathology, and what do you think will be the antibodies seen in this pathology? Can anyone comment? I'm sure you guys must be answering that in like a rapid fire. That's a classical case, right? So loose stools, abdomen pain. Though I am sure quite a few guys must have not looked at the image. You must have looked at the options and said that okay, loose stools, malabsorption, diarrhea. The first disease comes to your mind is, yeah, I'll do it, Amit. The first disease comes to your mind is celiac disease, right? Obviously, the first disease which comes to your mind when you look at all these histories, celiac disease, you must have looked at the option. Anti-gliadin antibody looks more possible. Then you must have looked at the image, right? Most of the guys will look at the option and then look at the image. Keep in mind, whenever you have an IBQ in whatever exam it may be, do the same thing because this image is a bit difficult to interpret. If you had interpreted, amazing, but it's a bit difficult than most of the images, right? So if you interpreted this image, amazing. But if you have gone with this history and looked at the option, narrowed down the diagnosis, that's a way going forward for every IBQ, not just in pathology, in every exam, whatever you attend. Because you're not pathologist, we'll definitely look at this image and we definitely look to the pathogenesis as well, right? So it's an anti-gliadin antibody. Let's see what's gliadin. Let's see how this antibody is formed and what is the pathogens behind celiac. A little bit in detail, fine. Bro foods are the foods which is involved in celiac disease. You guys know that it's barley, rye, oats, and wheats, right? What is the common component which is present in all these bro foods? Just to comment, whatever comes to your mind. It's a very simple component. All the bro foods, all of them, predominant one of the component is gluten, right? The celiac is otherwise known as gluten sensitive enteropathy, right? So whenever any person consumes gluten, be it you, be it me, it will always be broken down. It will be broken down by an enzyme called as TTG. What does TTG stand for? I want you guys to come and be active so that you don't get lost away. You will revise all the things about celiac disease along with me, right? TTG stands for tissue transglutaminase, right? So once tissue transglutaminase is there, it will be converted to gliadin. For you, for me, and every normal human being who's not predisposed to celiac, this gliadin will be excreted. Nothing will happen for us. It's a fiber, it's a dietary fiber. I won't be digesting them. I'll just push it in the feces. It's not a problem at all. Right? Who will have the risk factor? There are two HLA molecules, which is HLA DQ2, DQ8. Any person with this HLA DQ2 and DQ8, this gliadin and its byproduct called as deamidated gliadin will be considered pathogenic. So this HLA is a very important risk factor. If you don't have this HLA, None of us is going to have celiac disease. Quite a few of Indians don't have that. Quite a few of foreigners have that. So that gliadin in people with HLA will be considered and picked up by my APC, which is my antigen presenting cells, the protein, right? It's an antigen. So it'll be picked up and it will elicit an immune response, right? So this immune response, what will happen is it will activate my T lymphocytes. Any antigen presenting cell will pick up your T lymphocytes. That T lymphocytes will destroy my enterocytes. It will cause enterocyte damage. Once my enterocytes are damaged, obviously the villi is gone. When the villi is gone, malabsorption happens and it goes away, fine? Sure, Fuzzy, we are doing our best, and hopefully the videos are ordered. We'll definitely, your notes, everything is in pipeline. We'll give you updates soon, fine? Okay, now let's come back to the pathogenesis. You guys are going to tell me if this is how the disease process is going to go through. My body should protect me against any disease process, right? So can I say if I produce an antibody against TTG, will the incident or will the symptom of celiac disease reduce? Is that right? It is right, right? If I produce an antibody against gliadin, will the symptom of celiac disease reduce? So I'm destroying them or not letting them form, so my symptom reduces. So this TTG and gliadin production is a part of the disease or effect of the immune system. They're not the path of the disease, right? It's an effect of the immune system, right? So these are the one which we are going to use for diagnosis. It's not the disease, it's the effect of the immune system, which will be seen in the blood. That's a serological diagnosis. TTG and gliadin, that's what came in MCQ, right? It's an anti-gliadin antibody which helps me to diagnose celiac disease. Again, one more important question: in this current era, do we need biopsy to diagnose celiac disease? I want you guys to comment. Do we need biopsy to diagnose celiac disease or not? Second follow-up question is, what will be the investigation of choice for celiac disease? Do you need an endoscopy or not? I don't require anything. You have a history, directly go ahead with the blood investigation. Look for anti-gliadin, anti-TTG or tissue transcriptomics antibody, and then please diagnose celiac disease, right? Again, one more leading question. Tell me one dermatological condition which is associated with celiac disease. I'm sure you guys know it, and I'm sure every dermatologist will be hell-bent on teaching you this forever. That's your dermatitis herpetiformis, right? So dermatitis herpetiformis is one of the dermatological condition which is very closely associated with celiac disease for the simple reason this antibodies to TTG will cross-react with few anchoring filaments, right? The antibody in dermatitis and herpetiformis which is getting destroyed is anchoring filaments. So the anchoring filaments will be destroyed by the TTG antigen antibody, so it will destroy it, right? Shivam Nagpal, coming to your question, this antibody will be present only during the episode. It will never be present always. Only during the episode, I'll have this antibody. Fine. Okay, great. That's in short about celiac disease. Now let's go and interpret the microscopic image, right? So this is a normal intestinal biopsy, right? Normal small intestinal biopsy. What are these structures? I just want you guys to name these structures. You can see the finger-like projections, right? Simple ones. I'm sure you'll answer it. What are the structures? You guys know that for sure. That's your perfect. That's your villi. So this is your villi, the finger-like projections. So the upper ones are villi. What are these tiny ones? The downward projections, the tiny ones like a cup. Those are your crypts. Perfect. We have a crypt and a villi. So this is my normal intestine. This is not celiac disease. This is how normal intestine looks. So when you look at the celiac disease, okay. When you look at the celiac disease, look at this. This is flat. This is flat. Fine. This is flat. So that's a flat villi. There's no villi at all. It's completely gone. It's flat. And what you look here is your crypt. Your crypt is extremely increased in size compared to the crypt of the normal intestine. You have it in comparison. So it's a flat villi. It's a crypt hyperplasia. Okay. And you have lots of lymphocytes and plasma cells in between. That's how it looks in your celiac disease. Fine. Okay. See, I'll be discussing in detail when we have the second year batches. This is for INI-CET. I cannot go slow below this, fine. So it'll be a bit of fast pace. It's a rapid thing which we are going to use it for prospective aspirants of the INI-CET, fine. So that's how celiac disease microscopy looks. Like some of you guys said, I don't want a biopsy at all for celiac disease. It is just for a confirmation. Serology is more than enough, and stop bro foods and automatically it can be taken care of, fine. Perfect. Next question. Fastest finger first again. Go to the diagnosis, come on the answer. With this question, we'll try to cover almost everything required for glomerulonephritis in a very simple way. I'll mute myself for a few seconds, comment on the answer. A, B, C, or D. It's not difficult to comment on A, B, C, or D. Change your name, but do comment. It's fine to make mistakes here. That's what is going to help you in a longer run. Okay, D. Anyone else wants to add? Okay, great, D. What if you have gone for answer D, right? It's a very simple thing. I don't have the age. If there was a patient age, what will be the ideal age? Children or an adult? That also I want you guys to comment on. Most likely it will be child, right? A patient with an abdomen pain, a classical finding, hematuria tells you it's a nephritic syndrome, and purpura over the legs, right? As a classical diagnosis of HSP. Again, one more leading question. This purpura over the legs, will it be palpable or non-palpable purpura? Again, a very simple question. There's a vasculitis induced purpura. It's not due to thrombocytopenia, right? These are vasculitis induced purpura, and vasculitis induced purpura or palpable purpura, right? So this is one clue you can look from the question. If the question says a palpable purpura, I'm dealing with the vasculitis and not with the platelet disorder, right? And the image depicted here, and we also had an IgA deposition too in the microscopy, and the perfect diagnosis is HSP. So what do you guys think is the difference between option A and option D? IgA nephropathy is also more or less the right answer, right? HSP was IgA nephropathy. Why did you guys go for HSP? That's very good. Quite a few of you, in spite of option A being IgA nephropathy, read through all the four options and opted HSP, right? Keep in mind, there are few things in your glomerulonephritis. If you have systemic manifestations plus your nephritic syndrome, your systemic manifestations includes your abdomen pain, your purpura, palpable purpura in the skin, right? This is equivalent to HSP. Same with one more condition. If you have the same nephritic syndrome, along with the nephritic syndrome, you have lung manifestation. Then only I can call it Goodpasture syndrome. Otherwise, it's just anti-GBM glomerulonephritis. When I have both lung manifestations or in the form of an hematemesis or something, plus nephritic syndrome in the kidney, I use a syndrome, Goodpasture syndrome, right? So these two are constellation of symptoms, not just that, right? When you have both of them, you go with the syndromic. If it's only related to kidney, go with this, fine. Okay, Diksha, I will do it. I'll maybe in the next class I'll ask them to reduce the slow mode. Fine. Okay, great. So let's now swim through the entire glomerulonephritis. Put your pens down. I hope if the slow mode is on. For me also slow mode is on. So if possible, keep answering yourself if you're not able to type. Fine. Okay, great. Uh, if I cannot do it the middle of session. I'll try it. Just a second. Give me a second. I hope if I'm able to try it. Text it. If it works, great for us, right? Okay, great. So let's see. We are going to discuss about glomerulonephritis. In glomerulonephritis, I have two basic differences. One is your nephritic syndrome. Other one is your nephrotic syndrome, right? It's nephrotic and nephritic syndrome. There are quite a few diseases which are pure nephrotic. There's a mixture of nephritic, and quite a few diseases which are pure nephritic. When you take membranous glomerulonephritis, on the other day, a student asked as well. There are 85% cases of membranous glomerulonephritis will present as nephrotic only. So I don't want an undergraduate to go and read the 5%. Let's complete the 85% and then let's read the 5%, fine? So predominantly what is the manifestation? If you remember that, that's more than enough. The very rare scenario, if it comes in a mock exam or anywhere, it's just to show the superiority of that particular application or the teacher. That's all, fine. If you know the 85%, that's more than enough for you to practice medicine. So that's definitely more than enough to ace an exam, right? So coming to this, when it's nephrotic syndrome, there are few clues to call what nephrotic syndrome it is. If it's a child, minimal change disease, obviously. If you see minimal change disease not there in the option, or if you have a question which says it is steroid resistant, can I say almost every case of minimal change disease will be will be sensitive to steroid? Is that statement right? It is right, right? So if it's steroid resistant and in a child, if you have a nephrotic syndrome, think of a congenital FSGS. anyone tell me what is the type, what mutation comes to your mind when you think of a congenital nephrotic syndrome or congenital FSGS? Have you heard about mutations with podosin nephrin, right? So this congenital FSGS are steroid resistant, and you have nephrin mutation will be there, and you have your podosin mutation. These are the mutations which are common in congenital FSGS that also will be seen in children, but it will be steroid resistant. Keep it in mind. Fine, perfect. If it's an adult, go for FSGS. Obviously, that's the most common nephrotic syndrome throughout the world, right? MGN, like I said, 85% of them will be nephrotic. Some of them might have nephritic picture also, fine. So these are few common ones in nephrotic. And you go to nephritic child, it's HSP or IgA nephropathy. Based on the clinical manifestation, take a call what you're going to diagnose. With lung involvement, Goodpasture syndrome. Without that, it's anti-GBM glomerulonephritis, right? I have one person called as an anti-GBM glomerulonephritis, which means it's same like Goodpasture syndrome, but only glomerulus is involved, lung is not involved, right? If it's sore throat and skin infection, go for PSGN. If it's a rapid deterioration, like 2 years back, one NEET question was there, right? Rapidly deteriorate within a few days, not 3 weeks, like in the last NEET exam. It should deteriorate within few days. If it deteriorates within few days, then go for RPGN, right? These are clinical clues for me to diagnose, okay, this is most probably this disease, nephrotic or nephritic pattern, right? Clinical alone is not enough. We have to have the microscopy as well. This is my favorite image, a normal glomeruli. I always feel that if you know normal, abnormality is a piece of cake. But unfortunately, we struggle with normal, right? I'm going to put 5 places. We are going to compare the same 5 places in different abnormality. And whenever we look at the abnormal image, I'll put this normal image by the side so that you can compare. You compare and you ace the exam. That's all. This is your normal glomeruli. That's a glomerular capillary. A capillary in a normal scenario will be always be empty, and this space between the capillary is your mesangium. Generally, mesangium only will be that much thick. It will not be thicker than that. It's a tiny mesangium, right? The capillaries is going to filter the urine, and this space is your Bowman space or the urinary space. And Bowman space will always be clear. If there is something in Bowman space, it's abnormal, right? Any space in my body is covered by parietal cells, visceral cells. The one which is very, very close to the glomeruli, I call them visceral epithelium, or in other words, you use the term food process. It's food process or visceral epithelium, right? And one is away from the glomeruli, you call them a parietal epithelium, right? So these are the normal 5 things which I want you to remember. If you are watching the video, if you want to take a screenshot, you can take a screenshot, or otherwise I'll give you the PDF at the end of discussion in the Telegram group as well, fine? So these are normal 5 things which I want you to remember. Now our role is to compare this to the abnormality, right? How long is the slow mode? So that I'll paste the images in that scenario so that you can comment. Can you guys comment how long is the slow mode? So this is again normal. I just want you to compare this normal to one more abnormal image which I'm going to show you, right? This is the abnormal image. For your ease of diagnosis, see, I don't have any history. I don't have anything. I have only one thing, which is the image, and I'm sure you can diagnose with only an image, right? For your ease, the upper half is normal, the lower half is abnormal. Tell me what is the diagnosis? That's long. It's a simple one. It's simple. FSGS, right? It's focal segmental glomerulosclerosis, right? So the upper half is normal, the lower half, entire lower half is pink in color, it's completely sclerosed. So it's an FSGS, focal segmental glomerulosclerosis, right? Perfect. There's an FSGS, it's not an IgA nephropathy. Arrhythmia doc, I'll show you IgA nephropathy and I'll tell you how to differentiate this versus an IgA nephropathy. IgA nephropathy has a mesangial expansion. This might look as a mesangial expansion. If mesangium is expanded, look at this place. My capillaries will be visible. In this place, what I circle, I am not seeing capillaries, which means there's a fibrotic process replacing everything. Fine. That's the difference between this and mesangial expansion. I'll show you mesangial expansion for sure. Fine. Again, normal comparison. So this is my problem here. I'm sure you guys must have seen this similar image multiple times. Here I am having something in the Bowman space which is compressing my entire glomerulus. What is this? That's the simplest one, right? As the simplest diagnosis, this is your crescentic glomerulonephritis or clinically I will call it a rapidly progressing glomerulonephritis, right? It's always in comparison with normal. Look at the beauty of the Bowman's capsule in this image. You can see the beautiful Bowman's capsule all over, right? The Bowman space, but here I'm not able to see the Bowman space. That's RPGN or a crescentic glomerulonephritis, fine? Okay, great. Again, the same normal image in comparison. If you look at this in comparison, can I say compared to this glomerular capillary, the thickness of the capillary in this image is more? Yes, it's much more thicker, right? It's just a thick glomerular capillary or a thickened basement membrane. This is how it looks in membranous glomerulonephritis, right? Your membranous glomerulonephritis just has very thick capillaries, that's all. It will not have inflammation, it will not have anything. I will also tell you why membranous glomerulonephritis doesn't have inflammation, right? It's a very simple extrapolation. Membranous glomerulonephritis, we have antibodies against PLA2R receptor. This is a predominant etiology. There are quite a few other things as well. PLA2R receptor, I'm going to have antibodies. PLA2R is phospholipase A2 receptor. If I'm going to have antibodies against phospholipase A2, going back to your general pathology, will arachidonic acid metabolites form? It will not form, right? When arachidonic acid metabolites are not being formed, my prostaglandins, leukotrienes, everything will be less. That's why, in spite of having an inflammatory pathology, I am not seeing inflammatory cells in the microscopy, right? So this is the reason why I'm not seeing inflammatory cells. It's just a thick membrane. Last NEET exam, right? You had a question of spike and dome appearance. Spike and dome appearance is seen in your silver stain. It's not seen in light microscopy. Can you see there are tiny projections like this on the capillary wall? You have to little bit focus. That's a classical spike and dome appearance. Right? The spike and dome appearance is a classical finding seen only in your silver stain, not in a light microscope, right? That's also diagnostic of a membranous glomerulonephritis, right? It's just the tiny projections which is seen on the surface of the capillary, fine? Next image. Okay. You have the same normal capillary. Let's compare to the abnormal. Here, if I look, can I say, Arrhythmia doc, this question is directed towards you. Are you able to see the capillary here? In spite I'm having a lot of pink color, are you able to see the capillary loop? You can see the capillary loop, right? I am able to see the capillary loop and I'm having excess of pink material, which is my mesangial material. So what's the diagnosis? This is your mesangial expansion. Okay, this is mesangial expansion, and mesangial expansion, like you said, could be one of the features, classical features seen in IgA nephropathy, right? So that's the difference between IgA nephropathy and an FSGS. FSGS is a fibrotic glomeruli. In a fibrotic glomeruli, you will not see the intervening capillary loops. In a mesangial expansion, the capillary loops will be expanded and pushed away, right? That's a main difference here. This is a mesangial expansion. Yes, like Monk said, MPGN could also be a differential diagnosis. IgA nephropathy could also be a differential diagnosis, right? Both of them are differential diagnosis here, IgA nephropathy or an MPGN. Obviously, I need your immunofluorescence. When IgA is positive, I'll call it an IgA nephropathy. When C3 is positive, I'll call it an MPGN. That's how I differentiate further between these two things, fine? Great. Again, a normal, just for comparison. If you look at this cell, will I be able to zoom? Great. What are these cells? Can anyone of you comment? There are lots of tiny cells which are seen in the glomerulus. Lots of them. They're actually very classical. Do they look like neutrophils? They do look like neutrophils, right? So see, that is enough for me to diagnose. I'm having neutrophils inside the glomeruli, which means I'm having a bacterial infection which is going to cause this glomerulonephritis. What infection is that? Perfect. Your diagnosis is sorted. You pick the neutrophils, your diagnosis is sorted. That's your classical case of an PSGN, right? So we call this an endocapillary hypercellularity. I'm having lots of neutrophils inside, and that's equivalent to the bacterial infection, which is causing the neutrophilic infiltrate. It's in post-streptococcal glomerulonephritis, or the newer term, it could be post-infectious glomerulonephritis also, right? It's simple clues which can help you to diagnose many big things, fine? Next. Again, a normal image for comparison. Look at this. I hope the 1.3 minutes cutoff is done. So I want you guys to comment on this. If you look at this image, here also the mesangium looks bigger, right? Like the image what we saw a couple of images back. Here also mesangium looks bigger. But can I say here the mesangium kind of forms a nodule? It kind of forms a nodule. It's not just a deposit, it's a nodular deposit. So tell me the diagnosis. There's a spotter, and I want everyone to comment on this. Every undergraduate should know this even without an history. It was asked once in an INI-CET exam without an history, right? This alone, I want you to memorize the image. How much ever Google images you see, that's completely fine. Like Arun said, this I want you guys to remember for sure. It's a KW lesion, right? I'm sure you meant KW lesion alone. Ignore that, right? It's a Clemenstein-Wilson lesion seen in case of your diabetes mellitus, or in other words, it's called as a nodular glomerulosclerosis, right? It's a nodular glomerulosclerosis seen in diabetes mellitus, a classical KW lesion. Shivam Nagpal, perfect. Amyloidosis is a differential diagnosis here. If it's in congruent positive, I'll go with amyloidosis. If it's PAS positive, I'll go with KW lesion. But for an undergraduate level, I would say if you don't have any other history, go for diabetes and KW lesion because that's much more common than amyloidosis, right? If you have any history such as amyloidosis, please go ahead with amyloidosis, right? Okay. So those are few images of glomerulonephritis. We have swum through few images, but this is the most important thing of all. Know the normal, compare to the abnormal, and you have a history of nephrotic syndrome. Never forget the history, right? Next question, I wanted to guys to comment the answer. The simple one. With this question, we'll try to read a little bit about leukemias. I'll mute myself for a few seconds. Comment on the answer. The options are very simple. I'm sure you guys must have commented, right? The option should have been, if I was an examiner, no, a cruel examiner, I would have put M1, M2, M3, M4. And not such a cruel examiner. It's a very simple case. You have a 20-year-old person present in the general medicine OPD with fatigue and weakness. The following observations were made. The most probable diagnosis, right? It's a very simple question. It's a very, very simple question. The first image, what you see is a classical case of an gum hyperplasia, right? I had seen two cases of gum hyperplasia. One was very classical, wanted to take the picture. The patient said no, right? The very classical case of gum hyperplasia. If you have gum hyperplasia, the first possibility any doctor is going to think of in terms of leukemia is AML M4 bar M5. Your periodontal diseases, that also can cause gum hyperplasia. So once I rule out that, once I come to leukemia, I'm going to think of this. Your phenytoin can cause gum hyperplasia, right? When I rule out every other drug history, every other oral conditions, then I'm going to think of a leukemia, right? I'll think of M4, M5 because the frequency of gum hyperplasia also with M4, M5 is definitely much more than in any other thing. But yes, M2 can also have because M2 is the biggest chunk. When you look at the image here, I'll zoom this image for an instance. There is one characteristic finding seen here. What is that? Can anyone tell? And live batch is starting from April 17th. I'll cover everything required for in hemodynamics, and quite a few of them will be then the bleeding chapter as well. What is this? As a classical OR rod, right? You can see a perfect OR rod here. That's a very classical OR rod. So this is a myeloblast. In M4, that is myelomonocytic leukemia, I'll have both myeloblast and your monoblast, right? It could be an M4 or M5, right? So it's definitely blast. The first rule of calling anything as a blast is the size. It should be at least twice the size of RBC. It should be at least twice the size of RBC. Then comes your high NC ratio. If OR rods is present, I think of a myeloid. If OR rods is not present, I think of a lymphoid. That's a very simplest way to classify myeloid and lymphoid, right? So you have an OR rod, you have a gum hyperplasia. So my diagnosis, like you guys said, it's an acute myeloid leukemia. Let's cover leukemia for an instance. For any leukemia, be it ALL, AML, CLL, except CLL, except for CML, for every leukemia, whatever comes to you, my investigation of choice is always flow cytometry. It's never biopsy, it's never bone marrow aspirate, it's always flow cytometry. Nothing else. For acute myeloid, acute lymphoid, chronic lymphoid. For CML, on the other hand, 922 translocation is more suggestive of me. So cytogenetics or PCR. Keep this in mind. For everything, I'm going to go for flow cytometry only, right? Like Abhinav said, inversion 16 can be associated with M4, M5 when you have lots of eosinophils, right? Perfect. So whenever blast is present, the simplest rule is count. what is the percentage which should be more than that to call it an acute leukemia? It's always more than equal to 20%. 30% is long gone, it's always 20%. If granules or rods are present, not present. If it's present, I call it myeloid. If it's not present, I'm going to call it lymphoid. As simple as that. I know, Arun, I have asked them to remove the slow mode, but they are not removing the slow mode. I'll make sure in the future classes slow mode will not be there so that you guys can easily comment. I do feel that when you comment, you make mistakes and you learn from the mistakes, fine? Okay. Okay, there are quite a few stains which can be useful to diagnose these leukemias. I'm just going to cover the stains so that, see, ultimately in an exam, you have, okay, they are looking into it if they can reduce the slow mode duration. If it helps, if it comes live, that will be great, right? So stains, ultimately, like I said, the goal is to diagnose a case, be it an MCQ or be it in real life. So stains help to narrow down something. Like if it's a PAS dot-like positivity, it's not just the PAS, also the staining pattern is also important. If it's a dot-like positivity in PAS, I'm going to think of an ALL. I'll show this image. This is very, very important. Dot-like or a block-like positivity. Both means one and the same. That's very, very important, right? Okay. Yeah, I did it. Thank you. XKGB. Right? If you look at the other things, MPO, PAS, and NSC, all these will help me to diagnose AML. Sure, Amit, I have told them, hopefully it gets corrected. All of them are helpful in diagnosing AML because like AML M2 and M3, MPO is enough for me. PAS will be required for AML M6. NSC will be required for AML M5, M4, M5, right? So here, all of them put together is going to be suggestive of AML. Like I said, MPO is myeloperoxidase, is for myeloid. M2 and M3 will be positive for MPO. M1 will also be positive, but less in number. We can put M1, M2, and M3. Your PAS, a circumferential positivity will be positive in M6, and dot-like positivity will be like a granular positivity will be positive in M7. M7 will have a granular positivity of your PAs. M6 I'll show you the circumferential positivity soon. And NSE is your non-specific esterase, which is positive for a monocyte or lineage, M4, M5. So these are clues for me to say, okay, these are the positivities which can help me to narrow down its acute lymphoid, acute myeloid, and what type of myeloid, fine? I'll show you a few images, again, just to swim through the entire leukemia in a gist. Okay? This is your dot-like positivity. This is PAS stain. Dot-like positivity suggests to often acute lymphoid leukemia. See, remember one thing, dot-like need not be always a single dot. It can be one or two dots as well, right? Hi, Jay. Right? It can be one or two dots. If it's a single dot also is fine for me. 2, 3 dots also is fine, but it's be a very prominent dot-like positivity. That's diagnostic of an acute lymphoid leukemia. It's fine. Next, what is this? What's the characteristic finding seen here? The classical OR rod, right? That's also a classical OR rod. So which suggests me it's a myeloid leukemia. That's all. It's a blast. Why I particularly put this here is this image was particularly shared because looking at this, when you look at this, what comes to your mind? I hope the slow mode is removed, or if you guys can comment, tell me what is the first disease which comes to your mind when you look at this cell. Whatever comes to your mind, tell me, because that will help me to avoid mistakes. I'm sure at least one student will think in the way I feel you will think. OR rod is right. What comes to your mind when you look at that one which is irregular nuclei? Does it ring a bell? Does it look like your clover leaf shaped? Kind of looks like a clover leaf shaped, right? So when you have this cell in an exam, do not jump and write adult T cell leukemia lymphoma. Right? Please don't do that. That's what I wanted to say. It's not, it is having an indentation. It's not a Sézary cell. It's not a smut cell. It's not an adult T cell leukemia lymphoma. This is nothing but a nuclear membrane irregularity. In an acute leukemia, also I can have nuclear membrane irregularity. Sézary or adult, your cloverleaf or flower-shaped cells will be commented only when everything looks the same. Same goes with Arun Sharma's comment. Whenever see hand mirror, don't call it lymphoid. Look at the entire thing. Don't diagnose with one symptom or one cell. If entire thing is having this irregularity, your Sézary or your ATLL, right? Adult T cell leukemia lymphoma, right? Otherwise, go for the predominant one. There's nothing but an aura. This is a simple case of an acute myeloid leukemia only, fine? Okay. Next, this slide I've shared multiple times as a classical faggot cell, right? You have the bundles of or rod cell, classical findings seen in APML. So AML-M3, AML-M3 have very classical pointers. AML-M3 will have faggot cells. One leukemia which can present with DAC most of the time is APML. Think about that. And APML will have a classical translocation of 15-17, which is one of the exceptions for the 20% blast, right? And what's the treatment for APML? You don't give chemotherapy for APML. What do you give for APML treatment? Treatment is ATRA, right? It's vitamin A, all trans-retinoic acid, or you can have an arsenic trioxide. You can have either all trans-retinoic acid or arsenic trioxide. Both of them are approved treatment for your APML or your acute promyelocytic leukemia. Just one leading question. Every leukemia arises from stem cell, which makes them CD34 positive. APML is CD34 positive or negative? APML is CD34 positive or negative? APML is one leukemia which is CD34 negative. Remember this. This makes it very unique because it's acute promyelocytic leukemia, right? It's arising from promyelocyte. It's not arising from your stem cell, right? It's not arising from a stem cell and it's arising from a promyelocyte. So it's negative for your CD34. That's very, very important. Rest every leukemia, be it your acute lymphoid leukemia or an acute myeloid leukemia, they are CD34 positive. There's one leukemia which is CD34 negative, fine. This is a fact and you have to remember it, fine. That's a gum hyperplasia. We just saw gum hyperplasia, but we failed to answer why there's gum hyperplasia, right? Because everyone knows gum hyperplasia means I'm going to think of an AML M4 and M5. The reason for gum hyperplasia is both of these two guys, be it M4 and M5, will have monocyte. Can I say a monocyte can easily go into a tissue compared to a neutrophil? See, a neutrophil will go into a tissue only when there is an inflammation. Can I say a monocyte automatically can go into a tissue and become a macrophage? They can, right? So the homing of a monocyte is generally into tissue. That's why the leukemic cells infiltrate here. Leukemic cells infiltrate your skin. Leukemic cells can go into the lymph node. So this causes tissue infiltration. So because of the monocyte or lineage, I'm going to have lots of tissue infiltration, which makes them prone for gum hyperplasia or extranodal involvement. This extranodal involvement was given a specific term. We call them an chloromas, right? All these extranodal involvement of blast is called as a chloroma. That's one of the characteristic finding, including gum hyperplasia. It's also a chloroma, right? AML-M4 stains for NSE, non-specific estrase. There's one more NSE, which is neuron-specific enolase, that comes in systemic pathology, fine? Okay. And the CD markers they are positive for is CD14 and CD64. This is a macrophage marker, remember that. Anything which comes from macrophage histiocyte will be CD64 positive, right? It will be positive for CD64, including a Langerhans cell histiocyte. Anything regarding histiocyte, macrophage will be positive for CD64, right? Okay. This image, if you look at this, is an extremely round cell, and the cytoplasm is in bluish cytoplasm, right? I have a blue cytoplasm. I have more or less a round nuclei. Both of them are suggestive of one leukemia, which is erythroid leukemia. And like I said previously, erythroid leukemia will also be PAS positive, but the only difference is it will have a circumferential positivity. Okay? When you have a circumferential PAS positivity, it's AML M6. When you have a dot-like PAS positivity, it's ALL, acute lymphoid leukemia, right? Shivam, coming to your question, yes, chloroma can also be seen in AML M2, but the frequency of association is more common in M4 and M5. Why I'm saying it's also seen in AML M2 is in AML M2, I can have differentiation into any lineage. It can become basophils, it can become eosinophil, it can become anything, right? So there also, when the abundance of blasts becomes, they also can go outside. Any leukemia for that matter can go into the extramedullary lesion. ALL can also go. But predominantly, if I see gum hyperplasia or chloroma, I will think of an M4, M5, right? But your statement is right. AML M2 can also have it, fine? Okay. This is a very classical clue for the next leukemia and the last AML, which is AML M7. It's megakaryocytic or megakaryocytic, right? The function of megakaryocytes is to give platelets. If you look at this, they have budding platelets which are seen out close to the cytoplasm. They're cytoplasmic buds, which are nothing but future platelets, right? So that's a megakaryoblast. That's how it looks. and AML-M7, you'll have microblastic leukemias, right? Quite a few findings. Which syndrome will have AML-M7? I'm sure you guys must be waiting for this question. Which syndrome has AML-M7? Down syndrome, right? Down syndrome will have AML-M7. Myelofibrosis is one of the important factors of AML-M7. See, remember this. It's a megakaryocyte. Okay? Most of the megakaryocytes or megakaryoblast, they will release PDGF, platelet-derived growth factor. This growth factor is the one which will cause myelofibrosis. That's why even in primary myelofibrosis, a chronic myeloproliferative disorder, megakaryocytes will be very, very, very weird. So remember this, whenever you have a disease involving megakaryocytes, it will always result in myelofibrosis because they secrete PDGF, which is a fibrotic agent, right? Right. Okay. Next question. Comment on this. Let's see. I wanted the slow mode to be removed for this question. Let's see if we can remove it. I'll keep myself muted for a few seconds. This is PYQ. I'm sure you know the answer by this time, but just if you can comment on it. The pictures of karyotype of an individual person is depicted below. Which of the following can be expected in this patient? It's a very simple question. The clue is in the corner. There are two X chromosome and a single Y chromosome. That makes the karyotype 47XXY. And 47XXY is diagnostic of your Klinefelter syndrome, right? It's diagnosis of Klinefelter syndrome. Klinefelter syndrome, you see, perfect. It's gynecomastia with long unicorn features and thin limbs, fine. Okay. See, polydactyly is a very, very common finding. I can link to most of the syndromes. A web neck is a finding classically a diagnostic feature of Turner syndrome. So this is definitely not a karyotype of Turner, so we'll ignore that, fine. So it's gynecomastia with thin limbs because of this karyotype, the XXY, fine, perfect. So the next few minutes, we'll be trying to understand how to diagnose karyotype even without any clinical scenario. Our goal is to ace everything without clinical scenario, without any help from patient. So when you go to the exam, you'll have help from the patient, plus you have the image, and you will definitely write the exam very well. Fine. Okay. There are very few rules to diagnose a karyotype. The most difficult thing is to make this image. Make the image is the most difficult thing. Because once that is sorted, you can diagnose them very easily. The difficult part will be going to the pathologist, right? So karyotyping, the first thing is count each pair of chromosome. When I say count, count like 1, 1, 2, 2. I'll just go back once. Count like this: 1, 1, 2, 2, 3, 3, 4, 4. Don't count like 1, 2, 3, 4. When you count like this, you can easily diagnose all the aneuploidies, right? It will help you to detect every aneuploidy possible. Once you count like that, when you see only one X chromosome, suddenly don't jump to Turner's, because that's by default. When I see one X chromosome, I don't even look at the gender. I'll write Turner syndrome. What if it's a male? Males will have one X chromosome only, right? If there's only one X chromosome, please look for Y chromosome, because it's one of the first mistakes when I did a real karyotype. I got a one X chromosome. I didn't even look for care for Y chromosome. It's like, okay, thinking of Turner's. Then look at the image, the form, which is a male patient, right? So when you have one X chromosome, always look for Y. If Y is absent, then yes, your diagnosis of Turner's is right? That's my first rule. You're just going to count. We can detect aneuploidies, and if it's only one X chromosome, look at for the Y chromosome, fine. Okay, it could be a normal male karyotype. Next, if all the numbers are normal, right? If it's exactly 46 chromosomes, look for the size of the P and Q arm. What do we mean by that is, it's a P arm, it's a Q arm. Compare them, because it's always a pair of chromosome. Let's say it's like this. And if this fifth chromosome, can I say here the P arm is deleted? It is, right? Diagnosis. This also came once in an exam. The classical diagnosis. I'm just going to compare diagnosis 3-Church syndrome, right? The 5P deletion, 3-Church syndrome. So by comparing the size of the P and Q arm, you can diagnose deletions, you can diagnose duplications. It's a very simple way to detect them, fine. That's also possible. You can detect every deletions possible, fine. Okay, that's my second rule. Count, compare. The third is the most easiest one. Look for arrow marks. So when I say look for arrow marks, when I'm writing down a karyotypic report to a medical oncologist who has done DM degree, still I put 9th chromosome on arrow mark, 22nd chromosome on arrow mark so that he can identify it as CML. So if I'm giving a CML karyotype for an undergraduate, I will put arrow marks, right? Look for arrow marks. It'll be like this. So this means it's translocation between 7th and 16th chromosome. If the arrow marks is there in the same chromosome, inversion, right? So if here also, if it's here only, if it's here, it's an inversion, right? So you should be able to identify with the arrow marks translocations, inversions possible. If in the same chromosome, same 16th, I'm having two arrow marks, it means it's inversion 16. Okay, that's how I would identify inversions and translocations. Fine. That's all. These are three rules. I know you have a slow mode on, but these karyotypes don't require more than 10 seconds to diagnose. So I'll keep on moving one karyotype every 5 seconds, but I want you guys to answer the karyotype maybe out loud so that you can make the YouTube team here next class they will reduce the slow mode off. Fine. Okay, let's have some fun. Let's diagnose. Diagnosing is the most easiest part. Writing an exam is the most difficult part. You guys are doing the difficult part and you are killing it, right? Don't worry, you're doing very well. Diagnose. I'll give you some time. Since it's the first karyotype, I want you to take time and diagnose. Count, compare, look for arrow marks. 1, 1, 2, 2, 3, 3, 4, 4, 5, 5. Everything is normal, everything is normal, everything is normal. This is the most difficult karyotype you will ever see in your life, which is a normal male karyotype. Abnormality is not difficult at all. Normal thing is difficult. Physiology is always difficult. Medicine is easy, right? So normal male karyotype. If you are able to diagnose normal male with confidence, you can diagnose every karyotyping which is put forward to you, right? It's a simple normal male karyotype. Now let's look at the history as well as the abnormal karyotype, right? It's a 16-year-old female with primary amenorrhea as the history, and you have the karyotype. I'm sure you can diagnose within seconds. 16-year-old male, primary amenorrhea, and you have something marked there. X chromosome is being circled here. There's only one X chromosome, and there is no Y chromosome. It's a female. Female with one X chromosome. Diagnostic, right? Turners. In your exam, you'll have everything. You'll have everything given for you. You'll have the history, you will have the karyotype, and plus you'll have options. Even then, please don't make mistakes, right? A very simple one, right? Perfect. Next. I'm sure you're getting into the group, and I'm sure you're telling the answers soon, right? Perfect. Right. 25-year-old male with UNICET habitus gynecomastia. Look at the karyotype. Again, count. All top is fine, fine. But when it came here, it's double X and Y chromosome. It's 47XXY. Our question was this one, right? The simple one. It's Klinefelter syndrome. Right? A simple Klinefelter syndrome, right? So we know Turners, we know Klinefelters, and you guys diagnose without even looking at the patient. You can diagnose without looking at the patient, right? 45-year-old, many ring sideroblast and dyspoisis, and then the karyotype given. If you don't have your slow mode on, if some of you can comment on the answer. This is an interesting one because karyotyping is not always for Turners and Klinefelters. I can use karyotyping for many things. Let's integrate. Where do you see many ring sideroblast and dyspoisis? And in this karyotype, 1 is normal, 2, 3, 4, 5 is normal, 6 is normal. This is not normal. I'm having only 1/7 chromosome. That's not normal. With the history and 1/7 chromosome, I'm going to call the 1/7 chromosome as monosomy 7. Am I right in calling that? Perfect, Swati. Right? It's a monosomy 7. Dyspoisis and ring sideroblast, you will be seeing them in myelodysplastic syndrome. And I have monosomy 7, which is also a classical finding seen in myelodysplastic syndrome, right? It's a classical case of an MDS. So karyotyping can be used for hematolymphoid neoplasm also. It's not only for your inherited disorders. I can use it for anything. Anything which is abnormality in chromosome, I can use that, right? Next. Let's see if we can diagnose this without history. Sorry, without karyotype. 10-year-old recurrent infections, prolonged QT interval in ECG. This becomes a bit difficult, right? At least for me, it's a bit difficult. Let's put in the karyotype. Let's see if we can diagnose it easily. There's a karyotype and there's one person circled. That makes my life easier. I'm just zooming the circled person. Can I say, when I compare the arm, this is smaller, Definitely this is smaller. This chromosome part is smaller than the adjacent one. So in 22nd chromosome, I'm having a deletion. Now let's look at the history. I'm having a 22nd chromosome deletion with recurrent infections and prolonged QT interval in ECG. Perfect. That's your Thy-George syndrome. So a karyotype can give you answers easily. Clinical history might not be easy always, right? So if you look at, focus on one thing. See, your exam is going to be simple if you are strong in few subjects. If you are weak in few, rather than that, for within a very short time with INI-CET, I'll say play your strengths. In 1 week or 1 month, you cannot play your weakness. Play your strength, make it much more stronger, and score more on that. So that weakness maybe if you're going to attempt the next NEET exam or next INI-CET, if you're in very early part of your preparation, do that for the next exam. Immediate exam, if you're marking for this INI-CET, play your strength, not your weakness. Fine, perfect. Chromosome 22 deletion, Dye-George syndrome. We don't want options for this. We don't want history for this. Look at the fifth chromosome. One is shorter, one is bigger. That's a classical case of an Dye-George syndrome, right? Sorry, this classical case of one Cre-Du-Chat syndrome. Okay, it's classical case of one Cre-Du-Chat syndrome. Perfect. Next, 35-year-old basophilia. This also you don't want an history. You don't even want a karyotype. This guy is enough. Basophilia has only one diagnosis, which is CML. So look for the 9th chromosome, I have an arrow mark. Look for the 22nd chromosome, you have an arrow mark, right? The classical translocation 922. For any translocation or inversion, you will have arrow marks. Once you don't have arrow marks, it's abnormal. Right? If you have arrow marks, it's classical CML 922 translocation. Right? These are very simple ways to diagnose karyotyping, right? Furthermore, there's a lymph node biopsy. I'm giving you a clue. Let's see who can diagnose this. That's a lymph node biopsy, and that's a karyotype. You have his karyotype as extremely classical clues here. Two arrow marks. I've highlighted the arrow marks also. Tell me a diagnosis. I want you to compare both of them, the image as well as the karyotype, and give a diagnosis. Both image and karyotype. Compare and give a diagnosis. In the image, I'm seeing multiple follicles, right? I'm right in calling them multiple follicles or multiple nodularity. The karyotype, it shows classical translocation 14-18, right? Which makes it perfect, Avani, which makes it a follicular lymphoma, right? Okay, follicular lymphoma. Johan, Burkitt is 8-14, right? Burkitt is 8-14 or 8-22 or 2-8, right? Amit and Johan, Burkitt has a different translocation. Here my translocation is 14-18, which is classically seen in follicular lymphoma, and these are multiple follicles, right? Okay. It's a classical case of follicular lymphoma. Fine. It's fine to make a mistake. It's completely fine. Don't worry about the mistakes. Okay. As a classical case of follicular lymphoma. Fine. So like I said, it's not always for syndromes. I can use neoplasms, any neoplasm. I can give a history of Ewing sarcoma and give a translocation 11-22. That also is possible, right? Because quite a few tumors have translocations, classical translocations. I can mix and match and create n number of questions, right? Okay. So inversion was translocation. This is what I was saying. The arrow marks here are wrong. Ignore that. If I have arrow marks in two different chromosomes, that is translocation. It's translocation 16-16. If the arrow mark is in the same chromosome, not even the pair, it's the same chromosome, which means inversion. Because inversion is like this. It's inverse to the same chromosome. It doesn't go to the adjacent chromosome. And if it goes to the adjacent chromosome, it's translocation. If it inverts the same chromosome, it's inversion, right? It's the wrong arrow mark. Don't do that, right? Okay. Perfect. That's how you pick up inversion as well as translocation. Right? So those are few things regarding karyotype. I hope any question which comes in this INI-CET of going forward, you will not make a mistake in karyotype. Look at the history always. Count, compare, and look for arrow marks or circles. You can ace anything in karyotyping. Fine. Now let's go to this. Comment on this. The answer. I'm sure you know this answer by heart by this time. Let's try to do read HPLC also this time. Answer. Shivam has gone with A. Quite a few of you there, right? So when this question came in the exam, quite a few of them were like confused what to go with it, right? So always first step in solving the question is arrive to a diagnosis. Once you arrive to a diagnosis, it's very easy for me to write on the answer. 14-month-old baby. It's not a mild disease, it's a very severe disease. 14-month is very, very severe hemolytic anemia only will be present very early in onset, right? And repeated blood transfusion, hemoglobin is 6.3. And last transfusion was done 9 months ago. So it means transfusion started very, very early, right? So there's a case of if it's a case of an hemolytic anemia, one hemolytic anemia which can present very early is thal major. Thal major, I have two things. I have beta thal and I have alpha thal. We have already read in detail about beta thalassemia. The way to diagnose beta thalassemia is HPLC or hemoglobin electrophoresis. But for the patient or the patients, my question is, which of the following will be done for definitive diagnosis? Parents HPLC is not required for me. It's a major case. I don't want to prove the parents are carriers. It's not required, right? If it's a minor, yes, trait, yes, I might require parents. But for a thal major, parents HPLC is not going to do anything for diagnosis. So that's not needed. Ferritin, again, no. I'll just take from someone comment on ferritin. I'll just take the thing in ferritin. Ferritin is not needed for diagnosis of thal major, but ferritin is very, very important in order to see whether there's a secondary hemosidrosis during follow-up, right? Ferritin is not needed for diagnosis, but to rule out secondary hemosidrosis, especially after repeated blood transfusion, the patient having repeated blood transfusion, to follow up, I require ferritin because ferritin will be elevated in case of hemosidrosis, normal in normal patients, right? That might be required. Bone marrow aspiration is not at all needed. Be it alpha thal or beta thal, I don't want a bone marrow examination. So 3 of the 4 options are ruled out. And the only one option I have is globin gene sequencing. Am I right in saying that be it alpha or beta thal, I'm not coming to a diagnosis with this history. I need more findings to call it alpha or beta. Any of the thalassemia, alpha or beta, if I do a globin gene sequencing, can I pick them up? It's not saying what globin, right? It's just the hemoglobin gene sequencing, that's all. Right? If I do the alpha chain and beta chain sequencing, both of them can be picked up with globin gene sequencing. More so diagnostic of alpha thal, because for beta thal I don't do it because I have perfect diagnostic mode of HPLC, right? So this is a case of a thal major. Since B, C and D will not help me to confirm thal major, the only one option left here is globin gene sequencing, right? So you might have slightly difficult question here. Yuhan, for IDA, 14-month-old kid with repeated blood transfusion is not the right presentation of an IDA, right? IDA might not present that early, and it's very early for an IDA to have, and it's very severe hemoglobin 6.3 to have for an IDA, right? So that's the reason I'm ignoring IDA. I'm going for hemolytic anemia and not going for IDA primarily, fine. Okay, we'll just look briefly, we'll swim through anemia again. So anemia, the way to diagnose first is obviously clinical history. Look for a few characteristic point, present, absent, I know what is the diagnosis. Like for IDA, like Yuhan said, you have an pyelonekia, think of an IDA. Obviously those are enough for me to diagnose something, right? You have an atrophic gastritis in history, think of megaloblastic anemia. Alcoholism, that can itself cause. Hypothyroidism, that can itself cause. Apart from the history, when it comes to the lab, the first thing I will do is my blood investigation, CBC, where my MCV comes in top, right? The one way to diagnose anemia is micro, normo, or macro. Anything less than 80 femtoliter microcytic, anything more than 100 femtoliter macrocytic. I'm not going to give you a Sitama mnemonic for microcytic anemia. I hate mnemonic because I cannot create mnemonics, right? I will accept my difficult things. Second, for me, when you go with the Sitama, S is sideroblastic anemia. That's the least common of the microcytic anemia, but that comes on the top. I just want every undergraduate to know 2 microcytic anemia. That's enough for me. If you know these 2, that's more than enough for me. 96-97% it's going to be iron deficiency anemia only. Thalassemia minor, yes, might be a differential diagnosis. Major also a microcytic, but like we saw in this case, it presents very early and very severe, so it will not come in the differential diagnosis of IDA versus thal, right? It's IDA and most likely thal minor. As I said, thal major also will have a classical microcytic anemia only, fine? Both of them will have. Okay, Normocytic anemia, only one I want you to remember. There are quite a few causes of normocytic anemia. AOCD is anemia of chronic disease. That's very, very important. Most of the chronic disorder, be it tuberculosis, be it rheumatoid arthritis, anything chronic will result in anemia of chronic disease. Macrocytic, obviously, first subclassification is megaloblastic, your B12 folate, and this is more important because compared to megaloblastic, alcohol and liver disease are more common cause of macrocytic anemia, and this came once in an MCQ. Hypothyroidism. Hypothyroidism can also cause macrocytic anemia, fine. But megaloblastic is classical B12 folate, but other things are much more common than megaloblastic anemia, fine. The first thing I will do is this, and my major focus is on this because, like I said, 95 to 96% of the cases of anemia in our country is going to be iron deficiency anemia only. Rest entire RBC chapter handles 5 to 10% based on the geographic distribution, right? Now let's look at IDA and THAL. Our main goal is to differentiate IDA and THAL. Like you had previous thing also, I have to differentiate between IDA and THAL, right? Let's say there are two things which helps me to differentiate IDA and THAL, which is RDW and Menster's index. Let's quickly look at that again. RDW means it's a degree of anisocytosis, variation in the shape of the RBC, or in other words, for easy understanding, range of MCV. So you are going to tell me what is normal RDW, right? I've talked for the past one and a half minutes, so I want everyone to comment. So slow mode will not be there, right? So if MCV is 80 to 96, this is normal MCV. Tell me what is normal RDW. I want you guys to comment, and I'm sure you can comment. What is the normal RDW? If MCV's range is 90 to 80 to 96, the normal RDW is perfect. It has to be the difference, right? It's approximately 14 to 16. That's my normal RDW. That's approximately 14 to 16. The number of units between 80 and 96 is 16. So that's the maximum RDW a person can have. That's a range of MCV what I was talking about, right? Now our only goal to differentiate here is between IDA and THAL, right? I'm sure you know this already. I'll give a different perspective about RDW here. If some of you are from hostelite, the only thing what you go when you go to school, your home is eat, right? That's the only thing you do when you go to home. In other words, can I say your food intake of yesterday cannot be exactly the same of today or tomorrow? Obviously, right? So in other words, can I say iron deficiency anemia, where the predominant cause is nutritional deficiency, will always be dynamic? It can never be the same. Food intake can never be the same. Some days I can get good amount of iron. You go and eat a date, have 2 cups of date milkshakes today. Today iron is amazing. Today's bone marrow RBC production will be amazing. But that's not correct anemia because next 10 days no iron. So IDA pathogenesis is very, very dynamic. So what happens is I'll have both normal sized RBC during the days of good iron intake and microcytic RBCs during the days of poor iron intake because it's dynamic. Can I say on the other hand, THAL will never ever vary due to nutrition or any other cause? It will not, right? So THAL is always static. In other words, THAL will always produce only microcytic RBCs, right? They'll always produce only microcytic RBCs, right? So now tell me, in which of these two, the range of MCV will be higher? One with both normal size and microcytic, or one with only microcytic? Let's say microcytic is around 70, normal is around 90. It will be more, right? So here I'll have a wider RDW. Here I'll have a normal or a narrow RDW, right? Concept is simple. Since IDA is a very dynamic pathogenesis, I'll have both normal and microcytic RBCs. The range of RBCs present in IDA is much more wider. But since THAL is extremely static, only microcytic, the range of RBC produced is narrow, right? So that's how it is, fine. It's very simple to identify. Remember this, you will never ever have a confusion regarding RDW. It's because of the pathogenesis, that's all. This is sorted. We'll go to Menster's index. You're not going to memorize anything. Maybe the formula I need to know. Maybe this I need to know. Degree of anisotrosis. If I know that, rest everything is sorted. Menster's is also same. Menster's is MCV by RBC count. Again, I have these two guys only. THAL versus IDA. It's going to help in differentiating these two only. Both in IDA and TAL, MCV is smaller, microcytic, right? Will knock it off. So Menster's index, in other words, is 1 divided by RBC count. Okay? That's what Menster's index is, 1 divided by RBC count. Now tell me, which of these two anemia bone marrow will proliferate, IDA or TAL? Bone marrow always proliferates in case of an hemolytic anemia, right? It always proliferates in the case of a hemolytic anemia. So obviously in thalassemia, which is an hemolytic anemia, bone marrow will proliferate. What will happen to the RBC count in thalassemia? Will become more. So I'll have more RBC count in thalassemia. On the other hand, iron deficiency anemia, bone marrow is not having food, not having iron, will it proliferate? It won't. So here RBC count will be low. If RBC count is low in IDA, what happens in case of Menster's index? The denominator is low. What happens to the numerator? It's simple mathematics you read in like preschool, right? You know, it's very simple. If my RBC count is low in IDA, it'll be more than 13. 13 is the magic number which you'll not forget. So if RBC count is high in case of a thal minor, Menster's index will become less than 13. Right? Again, you might remember mnemonics. The only concern with mnemonics is it's very difficult to remember all the mnemonics at one point of time in exam. Use logic. You know this, right? You can write anything. You can write any variation if I know the formula. It's 1 divided by RBC count. Thal has more RBCs, less Menster's index. Iron deficiency has less RBCs, more Menster's index. That's all fine. That's two things, Menster's and your RDW. Fine. So that helps me to differentiate IDA versus TAL. Next question for me is, how do I diagnose TAL major? That was the question, right? So TAL major, I have beta TAL and I have alpha TAL. Beta TAL, it's two things. HPLC is any day better than hemoglobin electrophoresis, but both of them are good enough for me. Any one option is there in the MCQ, go ahead with that. But if both options are there, choose HPLC. I'll tell you why HPLC and not why hemoglobin electrophoresis, fine? Alpha TAL, there are two different things in alpha TAL. There are 4 alpha chains, right? 1 alpha deletion and 2 alpha deletion is not a concern for me because they are not symptomatic, fine? Okay. Pankaj, we'll answer your queries later. We have much more concerns here and we are very old for that to comment. Your teachers will comment better than us, fine? So the 3 alpha deletions and 4 alpha deletions are the one which is important for me. HPH is the 3 alpha deletion, right? There's a 3 alpha deletion which will be like a thal major, which will be presenting like a thal major. So I need to differentiate from beta thal. Same blood transfusion will be required. Same anemia much earlier in life as well, fine? The HPH, one of the important clues here is this golf ball inclusions. This is seen in a reticulocyte stain as a classical way to diagnose HPH. Right? The 4 alpha deletion is your hemoglobin BARTs. And the easiest way to pick up 4 alpha deletion is they delete the presentation will be in utero. Right? So in 4 alpha deletion in hemoglobin BARTs, I'll have 4 gamma chain. It's gamma 4 tetramer. It will be full of hemoglobin, right? There'll be gamma 4 chains. Gamma will never release oxygen. So the hemoglobin will hold all the oxygen, will not give any oxygen to the developing fetus, which results in hydrops fetals. When you have hydrops, in case of a hemolytic anemia, it's 4 alpha deletion. And HBH and beta thal, symptomatically it will be same. And I have a clue which is golf ball inclusion, right? So this is how I differentiate thal major and how to diagnose them. Let's look at HPLC and hemoglobin electrophoresis. You must have seen this image multiple times. Hemoglobin electrophoresis also is like karyotyping. All the hi-fi things are very easy to diagnose with rules. The first rule for hemoglobin electrophoresis is compare. When I say compare, you will always have control. And then you will have patients. All these are patients. Okay. You should always compare with the control. So you know what is present, what is absent. Second rule, whenever you have HbA2, think of thal. Generally, it's only thal minor, not thal major, but just think of thal. I'm just simplifying it a little bit. Right? Third rule, whenever there's HbF, like Johan said, think of a severe hemolytic anemia. Any severe hemolytic anemia, I'll have increased HbF, which can be sickle cell anemia or sickle cell anemia homozygous or Thal major. Both of them are severe hemolytic anemia, right? So with these rules, you can diagnose an XLH hemoglobin electrophoresis, right? Like I said, this is the control, the first image. Look at the second one. HbA is there, okay. HbF is not as much increased as my control, it's decent, but HbA2 is increased than my control, right? Slightly increased, but no increase in HbF. So A2 is present is Thal, no HbF, it's Thal major or Thal minor? Simple, it's a Thal minor. Okay, this is a Thal minor or a Thal trait. It's very simple rules. HbA is elevated, no increase in HbF, so it's a Thal minor. Look at the next one. HbA2 is elevated, HbF is very high, so this is a Thal major. Again, always compare with the first one, which is the control. Next one, the third image, HbS is there. At the same time, HbF is not increased. So it's a sickle cell anemia trait. It's a carrier state. It's not a full-blown sickle cell anemia because HbF is not elevated. Look at the last one. HbS is elevated. HbF is also elevated. That's your homozygous sickle cell anemia. See, this image has been used multiple times in multiple places, right? This is one of the easiest image to interpret every hemoglobin electrophoresis. I'm sure you guys know. And these are the cardinal rules. Always compare with the control. If you don't compare with the control, you lose it. Not just you. You give me an electrophoresis without a control, no one in the world will be able to diagnose, right? And whenever HbA2 is elevated, think of that. HbF, think of severe hemolytic anemia. These are thumb rules to diagnose any hemoglobin electrophoresis, right? Now let's look at HPLC, because we have not discussed HPLC till now. And if it comes in an exam, it'll be good for you, right? HPLC also is the same. The only difference is it gives in percentage. It gives exactly how many percentage is present. That's what is important. First rule in HPLC, do not look at the peak. Because if you look at the peak, it looks like F is so much, right? It's written hemoglobin F, that is looks so much. Don't look at the peak. Always look at the percentage. Don't look at the peak at all. In hemoglobin F here, it is 8.4%, that's all. This is A. Hemoglobin A is 78%. I'm just going to reduce them. Hemoglobin F is just 8%. Hemoglobin A, that's my adult hemoglobin, is 78%, and hemoglobin A2 is 4.9%. Tell me your diagnosis. Never ever look at the peaks, always look at the percentage. What's the diagnosis here? A2 is elevated. Yes, anything more than 3.5 of A2 is considered abnormal in India. So 4.9 is elevated. F is not that elevated. It's elevated, but not that much. When I say 20 or 25% more, I say it's significantly elevated, right? A is also there, A2 is elevated, that's a Thal minor. Perfect. It's the same rules of HPLC, hemoglobin electrophoresis, but the only thing, don't look at the peak, always look at the percentage on top. This will be given for sure. That comes in the HPLC report, right? Always look at the percentage, do not look at the peak. We'll try one more thing. Okay, this again a peak. Always look at this. HbF concentration is 95. HbA2 concentration is 3.9. What's the diagnosis? HPLC is also not difficult, right? It's also very simple. Very simple diagnosis. That's your Thal major. I'm sure you guys won't have the slow mode to comment on. I'm sure I have confidence in you that you must have diagnosed that, right? Extremely high HbF tells us a severe hemolytic anemia. Like I said, anything more than 3.5 HbA2 is abnormal, 3.9 is abnormal. So it's a thalassemia, which is severe, which is Thal major. Fine. Okay, that's a severe hemolytic anemia. I can actually diagnose alpha Thal also here, but we'll not go into it now. Maybe when you become postgraduate, let's learn about HPLC, right? It's these are very simple ways to diagnose things, right? So it's not just hemoglobin electrophoresis. We also will be able to diagnose HPLC as well, fine. So that covers a little bit about all the anemias required for us, fine. Let's go to one more question. Let's see if you can comment on this. It's a simple one. Actually, why we have this color? That's more fascinating than others. Diagnosis. I'm sure you guys know this answer. There's a classical knuckle hyperpigmentation seen in case of an your B12 deficiency anemia, right? I'm sure you must have answered it. The slow mode is stopping all our progress and will definitely be technology. We'll grow more, right? So it's a 22-year-old person with EC fatigability and pallor, and you have the classical image as shown the hands of the person as a classical case of an B12 deficiency. What we have is a classical knuckle hyperpigmentation. Okay, it's knuckle hyperpigmentation, that's all, fine. So the reason for knuckle hyperpigmentation is, see what happens here is when you have slow mode B. Okay, so when you have B12, see B12 is one of the important functions of B12 is to produce thymine, right? They help in synthesizing thymine. In such, because they produce thymine, they help in the DNA proliferation or DNA division, which indirectly helps in the cell division. That's all. So B12 is equivalent to cell division. In other words, whichever cells in my body are very highly proliferating, they are all dependent on B12 for its survival. So am I right in saying that my skin also is highly proliferating? It is highly proliferating, right? So can I say skin also will be dependent on B12 to maintain its thickness, its stratified squamous epithelium? It is, right. So what happens in B12 deficiencies, since my amount of B12 is less, my skin cannot maintain its layers. My skin becomes very thin. If my skin is very thin, and when I bend my knuckles or the elbow or a malleolus, am I right in saying that if it's a thin skin, it can get injured or traumatized? It can, right? So here in this patient with B12 deficiency, what's happening is the skin is having micro traumas because the skin is thin than a normal patient. When the skin and these knuckles have micro traumas, my skin should react. Wherever you traumatize skin reacts by producing pigment. That's the way by which a skin reacts. You guys know that if you wear spectacles, this part of your nose will become black in color. It's trauma to the skin. It's trauma. Allergic nasal solute, trauma. So whenever there's a trauma, my skin responds by producing pigment melanin. Your mother would have told you, don't go in the UV rays. Sun can produce trauma and make you black. Don't keep on scratching, it'll make you black. If you have very tight pants, the waistline will have black line, trauma to the skin, right? So these are nothing but trauma to a skin which has become thin because of B12 deficiency. That's why knuckle hyperpigmentation is seen in B12 deficiency, right? A very classical sign. Like your koilonychia, it's a very, very classical sign for B12 deficiency, right? Next time when you see a patient with B12 deficiency, look for that. It will be present. If it's not present, it's not B12 deficiency, right? Okay, we'll just go through few images. What is this? Can anyone comment on it? I'm sure 1.5 minutes of slow mode is over. Comment on what you're seeing here. Comment whatever comes to mind. Something should come to mind, right? Anything which comes to mind, you can comment. Okay, that's your the most difficult thing again. That's your normal RBC, right? Normal are always difficult for us. Normal karyotyping is difficult for us. Normal RBC is difficult for us, right? That's nothing but a normal RBC. I just marked it so that you will think of some abnormality. That's all. This is marked because that's a normal platelet, right? Johan, I'm hitting you again, right? So normal karyotyping, again, this also, it's just a normal RBC, right? That's a normal RBC. You have the central pallor. The central pallor should be always be present. The central pallor will be 1/3. Central pallor will be exact round, right? That's a perfectly normal RBC, right? If you made a mistake here, it doesn't matter at all. It's completely fine. But now at least you know that whenever something comes to you in an image, you should look for normal first. Patients also, when they walk in, they're always not having symptoms all over. They might be normal as, right? That's a perfectly normal RBC. Once they know normal, I can rule the world of abnormality. Right? That's normal RBC, that's all. Now let's compare this normal to abnormality. That makes a life much easier, right? Again, one is normal. Look at the size here. Is the lymphocyte. Now tell me what's happening to this RBC. Comment on the size. Comment on the pallor. Is it 1/3 or more than 1/3? Can I say it's more than 1/3 and it's smaller? Perfect. That's completely a microcytic hypochromic RBC. That's a classical case of an IDA. Beta thal also will look the same. Microcytic hypochromic RBC. There's definitely variation in the size. Anisocytosis, poikilocytosis also there. Kind of looking elongated. There are lots of poikilocytes here, right? The classical case of an IDA. Again, this for a comparison normal. The color might look different, but I'm sure you can pick up the paler, you can pick up the smaller cells. That's for IDA, right? Next, what is this? This everyone will jump into. But case of megaloblastic anemia, to see this much classical, I have seen in my entire pathology life, maybe 20, 30 megaloblastic anemias. Classical with hypersegmented neutrophils. It's not that common. ID is extremely common. That's a classical hypersegmented neutrophils. See, because why it's not common is nowadays everyone is popping up vitamin pills like snacks, right? So it's not coming into persistence and all. That's all, right? So it's 1, 2, 3, 4, 5, 6, 7, 8, almost 8 lobes. Any single neutrophil with more than 6 lobes quantifies for hypersegmented neutrophil, right? That's classical case of megaloblastic anemia. Maybe B12, maybe folate, doesn't matter. Now just a question, follow-up question. B12 deficiency versus folate deficiency. What clinical history will help you to differentiate these both? First question is, should I differentiate the both? If I have to differentiate the both, what clinical history will help me to differentiate the both? Because both will have hypersegmented neutrophil, both will have skin pigmentation, both will have anemia, both will have everything, except for one. B12 will have neurological defects. The subacute degeneration of spinal cord, you must have heard about them. The tingling problem, the vibration sense, all of them will be there in B12. There'll be no neurological defects in folate deficiency. It'll be negative. That's very, very important. The next question is, should I differentiate that? The answer is absolutely yes. I should differentiate that. When I was doing MBBS, the way of teaching was when there's a B12 deficiency, treat the patient with both B12 and folate. That was way back. They have changed the entire protocol. That's why we always should stay updated. 2, 3 years back, when AIMS was there, I think the last AIMS exam had this question. When there's an isolated B12 deficiency, the treatment is only B12, not both B12 and folate, right? In case of an isolated B12 deficiency, the treatment is not both B12 and folate, the treatment is only B12. This is very, very important because if you give both B12 and folate, it will worsen the neurological defects. This came in an exam. There's a change in protocol, but it is years back, right? So please don't read years back text, which will definitely land up you in trouble, right? So it's B12 deficiency was folate is very, very important for me to treat them, right? And neurological defects is one thing which will give me a clue B12 or folate. In addition to the biochemical test, biochemical test obviously will help me, but in addition to that, clinically it will help me as well. Fine, right? Next, diagnosis. I don't have the normal by the side, but still I am sure you can diagnose them. Normal shouldn't have gone out of your mind so soon, right? Diagnosis. Anyone can comment? It's a This is the RBC which I'm looking at. All these RBCs. The one classical finding in these RBCs, none of them or most of them are not having central pallor. It's completely dark red in color, right? No central pallor, perfect. As a classical spherocyte. Classical spherocyte. No central pallor, smaller, darker RBC. This NEET also had the same confusion. Whenever you see spherocyte, what's the first diagnosis? First diagnosis is always autoimmune hemolytic anemia. That's always the first diagnosis. Then only I'm going to go for hereditary spherocytosis. Okay, there are lots of confusion regarding the recall, but in this NEET exam, but I'm not exactly sure what's the question. But whatever said and then, when there's spherocyte, the first answer should be AHA and then only hereditary spherocytosis. Do not think of spherocytosis first. Right? Okay, that's a spherocyte. Diagnosis. Sarika, I'm just going to tell it as spherocyte. I'm not going to give a diagnosis. I'll just keep it as spherocyte. Okay. What is this? That's an elliptical cell, right? That's an elliptocytosis. We have hereditary elliptocytosis in addition to spherocytosis. You might have a confusion. How do I differentiate this from a pencil-shaped RBC? Because pencil-shaped RBC is also elongated, right? Elliptocyte versus pencil-shaped cells. And pencil-shaped cells are seen in IDA. And I need to differentiate them for sure. Right? I need to differentiate both of these two. There's one easy way to differentiate. We'll go back to the IDA image so that we'll see if we can get some clue. Can I say this is kind of an a pencil-shaped RBC? Though not exactly, but it's elliptical, bit elongated. Is it well hemoglobinized or pale? That's extremely pale, right? So if it's a pencil-shaped RBC, seen in case of an IDA, it will be extremely pale. It will not be red in color. But an elliptocyte will be well hemoglobinized. The main difference between elliptocyte and a pencil-shaped RBC is the paler. If it's pale IDA, not pale elliptocyte. Fine. That's all. Next. Diagnosis. As a classical cell, I'm sure you will diagnose this. You must have seen this multiple times. That's your white cell, right? Seen in your G6PD deficiency, right? Classical white cell seen in G6PD deficiency. Perfect. Okay. What's the one more structure seen in G6PD deficiency? White cell and what body? The Heinz body. Heinz body will not be seen in a routine stain. It will be seen only in a new methylene blue stain. The classical white cell and Heinz body, both of them are seen in G6PD deficiency. Fine. Next. Diagnosis. Johanna, I'll come to histiocytes soon. Diksha, image quality in exams is a major concern. I maximum on all your behalf, I'll write a mail to NBE. That's what maximum I can do. You can also do the same thing. Hopefully, they'll have some sense to give good quality images, right? That's a classical target cell, right? That's a classical target cell. The multiple target cells here. Whenever I have target cell, my first thought is thalassemia. It's not just thalassemia. In addition to that, I can see target cell in IDA also. I can see target cell in sickle also. So don't just blind ourselves only with thalassemia. I can see them in multiple places. Thalassemia, IDA, as well as sickle cell anemia. Right? Okay. Target cells. There's one more technical term for target cells called as codocytes. See, the only way they can create a new question is change the name. Codocytes and target cells mean the same. It will be seen in all these three conditions. Right? These two, especially these two, they are very irregular and they're not very sharp. They are very irregular and they're very blunt. When you have an irregular projection of the cells and when they are blunt, that's an acanthocyte, right? That's how an acanthocyte looks. Acanthocyte or your spur-shaped RBCs or your spur cells. One thing which whenever acanthocyte comes in an exam or whenever I take class, everyone shouts one thing uniformly: A beta lipoproteinemia. I'm not against A beta lipoproteinemia, but I'm very for liver disease. Because I would say a liver disease is more important for me than A beta lipoproteinemia, because liver disease is extremely more common than A beta lipoproteinemia, right? The liver disease is one which is more common. Obviously, A beta lipoproteinemia comes later on, right? That's an acanthocyte, spur cell, liver disease, or A beta lipoproteinemia, fine. Next, when you look at this, I'll just go and compare the previous one also. Look at these cells. I am definitely right in saying that the projections here are very uniform. It's very irregular. It's regular. When you have a regular and a blunt projection, that's your burst cells or your echinocyte. Echinocyte or burst cells are seen in CKD, chronic kidney disease. That's a classical findings in CKD. They are uniform and they are regular, right? Uniform and blunt, regular, that's echinocyte. Irregular and not uniform, it's an acanthocyte, fine. Okay. This is spotter. What is this? Everyone should answer this, right? These are very classical cells. Those are your sickle shaped RBC. The only thing you must also remember, I have one more name called as trypanocyte. I have trypanocyte or a sickle shaped RBCs or a sickle cells, right? Do remember them as well. Yeah, echinocytes are also called as burst cells. You're right, Abhinav, right? Okay. a few RBC images, and we know how to handle your B12 with folate deficiency, and we also know the reason for knuckle hyperpigmentation, right? Okay, next question. Comment on the answer, but this was also PYQ, right? We are discussing only the PYQs. Whenever the PYQ come, it becomes a very important question, and later on it becomes very easy one. So this is important. I'll use a timetable. So I'll use a table from Harrison, because the Harrison has an amazing table of the CK20 and CK7's utility, right? It's a CK20 positive and CK7 negative. Which of the following is my differential diagnosis? Answer. It's a classical case of an colorectal carcinoma, right? 20 positive, 7 negative is a classical diagnosis of an colorectal carcinoma. This CK7 and 20 is something which is very commonly used in pathology. I have put purposefully these blinders so that I don't want you to remember them, because these overlap a lot. But the ones which are not overlapping, I want you guys to remember for sure, right? If we do CK7 and 20 quite commonly, CK7 negative, CK20 positive, like in our question, I think of a colorectal carcinoma or a Merkel cell carcinoma. Merkel cell is very important for diagnosis, though it comes in many places. It can come in skin also, but most likely it's colorectal carcinoma. Anything in your lower GI, anything in the lower GIT, it comes in the CK20 positive, CK7 negative. Just remember like this: your upper aerodigestive tract is CK7 positive, lower GIT is CK20 positive, right? So this is CK7 positive, CK20 negative. One easy way to remember them is the upper GI tract, upper aerodigestive tract, not just GI. So lung also is upper aerodigestive. Salivary gland is upper aerodigestive, right? Breast, thyroid. Again, it comes from this kind of similar origin, similar location, right? All of them are CK7 positive, 20 negative. Female reproductive organs, two of them is also positive. For me, even if you forget endometrial and cervical, I don't have much of a problem, because I diagnose endometrial cervical with ERPR. I'm not going to diagnose with your CK720. But anything upper aerodigestive, I want you to remember, especially salivary gland, lung adenocarcinomas are positive, breast and thyroid cancer are positive for CK7, negative for CK20. The extremes, both being positive, ovarian and urothelial, both being negative. This is very important. See, both being positive, ovarian and urothelial is not that important for me, because I have very specific markers for both ovary as well as genital tract, right? But both being negative, it gives me a clue. Where these are all useful is metastasis. When I have an unknown metastasis, if both are negative, then I think of a renal cell carcinoma, prostate, or a hepatocellular carcinoma. This is very important in diagnostic point of view, and 7 and 20 is also important diagnostic point of view. This might, we can put into a waste basket category, right? The ones which I've hidden, it's pancreas, gallbladder, and everything, which is a very varied expression. It will come in every category, so I'll ignore that, right? So both negative might be the prospective question. Maybe 20, which is colorectal, which was previously asked. If I have to ask something diagnostically for my undergraduate to know, I'll go for this category: hepatocellular, renal cell carcinoma, and prostatic adenocarcinomas. Fine. Okay. I want you guys to remember a few more classical IHCs. I'm sure quite a few of you will remember this, know this already. Squamous cell carcinoma, P40, P63. Lung adenocarcinoma is your TTF, TTF1 and absent A. Neuroendocrine tumors have three things: synaptophysin, chromogranin, and NSC. In addition to this, you can have CD56, 57, but these are important. Anything glial, ependymal, astrocytomas, oligodendrogliomas, all glial tumors are positive for GFAP, glial fibrillary acid protein. The previous thing I said, right, genitourinary have a very specific marker, GATA3. Anything from genitourinary, ovarian, urinary tract, your urothelium, your ureter, everything is positive for GATA3, so that I don't need to remember about the first category in the flowchart, right? Leiomyosarcoma, SMA stands for smooth muscle actin. So you need not memorize that again. It's smooth muscle actin. It's leiomyoma, leiomyosarcoma. Angiosarcoma also, you need not memorize it. I'll just ask you a question. Let's see how many of you guys can correlate and answer that. In your inflammation chapter, you must have definitely read about diapedesis, right? What is the molecule which helps in diapetesis? Comment on the answer. I'm sure you guys know this. Diapetesis is the process of transmigration. Tell me whatever comes to your mind. A molecule responsible for diapetesis. I want you guys to comment. The reason for asking you to comment here is to make sure you believe that you know medicine. No one? I'm sure you guys know. That's your PCAM1, right? If you remember PCAM1, perfect. There only you must have read the other name for PCAM is CD31, right? I'm sure you must have heard this. The other name for PCAM1 or PCAM is your CD31. Perfect. So in other words, what I'm trying to do in pathology is, I know this already, it's present in every normal endothelium. So a tumor coming from endothelium, angiosarcoma, will also be positive for that. You had CD95 is seen in your apoptosis. The FAS ligand is FAS ligand is CD95, fine, not this, fine. So angiosarcoma or even your Kaposi sarcoma for that matter, all these are endothelial tumors, right? If I'm having an endothelial origin tumor, they will be positive for definitely your PCAM, right? Your PCAM is CD31, which will be positive here as well. So in other words, if I know normal, I can know abnormality. I'll go back once again. All these CK is nothing but embryogenic proteins. So if I have made sure I ace embryology perfectly, I know normal physiology, anatomy, I will know entire medicine. That's where we had a trouble, right? Our trouble was first year. Our trouble was always first year for most of us, right? It's all extrapolation of whatever we read in way early in your life, right? Maybe once you finish your INI-CET, you score an amazing rank in INI-CET, go back to the first year, read physiology. That's the best one what anyone can do. Then pathology, then medicine will always take its way, right? Okay. Next question. This is a very simple one. Let's comment on whatever comes to your mind. Which of the following will not affect the in vivo clotting mechanism? It's factor 12, right? I'll tell you why this question is important. Because I'm sure you know the answer of the question. You know that it's not inside the body, factor 12 is not required. The reason why I want every doctor to know this is, am I right in saying that this factor 12 will be involved in the lab? This is not involved inside the body, but in the lab, you must have remembered this Y-shaped structure, right? Extrinsic pathway, intrinsic pathway. It starts with factor 12, right? Factor 12 is involved in the lab diagnosis, but it's not involved in the body, which means you and me, when I have a cut or an injury, even without factor 12, I'll form a clot. But when I take a blood outside and test it, without factor 12, intrinsic pathway will not function properly. So why this is important is, let's assume a patient has factor 12 deficiency. Listen carefully and answer to me. Will this patient have bleeding disorders? Factor 12 is not involved in vivo clot mechanism. Will this patient have bleeding disorders? The patient will not have bleeding disorders, right? There'll be no bleeding tendency because factor 12 is not involved in natural body. At the same time, when I do investigation for this patient, what will happen to APTT? Will it be elevated or normal or reduced? Because factor 12 is important for lab diagnosis. My APTT will be elevated. Okay, the APTT will be elevated. An elevated APTT with no bleeding history, you should think of this. And there's one more diagnosis with the same history. Elevated APTT with no bleeding history but thrombotic history. The same thing. In addition to this, one more symptom, thrombus formation. You have to think of Apla syndrome. See, these are the ones which you will make you to solve the things in your real life. You might definitely encounter this. Lab will say elevated, patient will be asymptomatic. You should not doubt the patient or the lab. There are possibilities for me. Apla syndrome also, ability will be elevated. but there'll be no bleeding, there'll be thrombus manifestation, right? So keep in mind, if APTT alone is elevated, when you have something not matching properly, these are two diseases which I want you to remember. That's the reason for this question. It's not a fact. No one cares about a fact. If a fact doesn't have a importance, don't read the fact, right? Okay. Now let's look at these things. PT, APTT, thrombin time. Thrombin time is nothing but fibrinogen assay. That's all, nothing else. APTT is your intrinsic pathway, PT is your extrinsic pathway. I'll tell you the normal values. Ideally, normal value should be given in the exam because all these normal values are my lab values. This can change even in my lab next month. They're very volatile based on the sample what I use, based on the reagent I use, right? So this can become 14 to 18 also. APTT can become like 40 also. My thrombin time also become like 20. It can happen, but this is very, very varied. Ideally, it should be given in the exam. But you know our examiners, they are very cruel, right? If they don't give in the exam, remember these values. Fine. Okay. Let's say I'm having this scenario. I'm having an elevated PT, normal APT, normal thrombin time, normal platelet count. Tell me your differential diagnosis. Whatever comes to your mind. Any differential diagnosis comes to your mind? Elevated PT, normal APTT, thrombin time, and platelet count. Diagnosis? I'm sure first differential diagnosis everyone will jump on is extrinsic pathway defect, which is factor 7 deficiency. But I will put factor 7 deficiency second. Okay? Because I'm sure you guys will jump to this. Because that's what easily comes to me, right? And everything rare comes to us first. What I want you to remember is going forward, it's not the rarity, it's always the common one. It's liver failure. So yeah, like I said, my role is not to teach you. My role is to tell you, you know stuff. If you are an intern or a post intern or anyone who has done a liver function test, LFT, am I right in saying that PT is a component of liver function test? It is a component of liver function test, right? It is. So whenever liver fails, the first clotting factor which will be lost is factor 7 because of its very short half-life. So whenever PT is elevated, think of liver failure first. You are not wrong in saying factor 7 deficiency, but it's a rare thing. Put it down the road, right? First, liver failure, because LFT, PT is a component of it, right? That's the first thing I wanted to think of, right? Next, elevated APTT, normal rest of them, possibilities. If APTT is elevated, rest of them is normal. My possibilities or my differential diagnosis is first one, I will want you to rule out von Willebrand disease because that's much more common than hemophilia. And second, do not jump to hemophilia. You have to do something called as mixing studies. This is also like a protocol. Like whenever you see spherocyte, I think of autoimmune hemolytic anemia and I do Coombs test. That's a routine question which has been asked. Whenever you have elevated APTT, that to isolated elevated APTT, the next step for isolated APTT, this was also asked once in exam, is something called as mixing studies. Do not diagnose them as hemophilia. That's a wrong prediction. I'll tell you why it's wrong very soon. Whenever you have an isolated APTT prolongation, next is mixing studies. I'll tell you what's mixing studies. Very simple study. I have an elevated APTT. I do a mixing study. What do I mean by this? I mix normal plasma 1 ratio and patient's plasma 1 ratio. Then I'm going to repeat APTT. When I repeat APTT, I have two possibilities. Either it can become normal or it's still elevated, right? These are the two possibilities. These are very simple possibilities, right? Let's assume it has become normal. So am I right in saying whatever this normal plasma gave has corrected the problem, corrected the patient's problem? Yes. I'm adding normal plasma to the patient's plasma and repeating the same test. When I repeat the same test, it's correcting the patient's problem when it becomes normalized again, right? Which means the primary patient's problem is reduced factors. The patient had reduced factors, so I added normal plasma, which is equivalent to treatment, right? I replace the reduced factors, everything is normal. In other words, still it's elevated, which means this normal plasma is also not able to take care of it. So can I say in this patient, the patient might have autoantibodies? If the patient's plasma have autoantibodies, I'm adding normal plasma. Will that also be destroyed? Will be destroyed, right? So there's autoantibodies, which is also destroying the normal plasma factors. So I'm having elevated APTT. My interpretation is very simple. If I have a normal APTT after mixing study, I have hemophilia A or hemophilia B. If you have elevated APTT after mixing studies, I have inhibitors to factor, which is autoimmune disease. It's nothing but autoantibody. Okay, I'm just having autoantibody. This is very, very important for us to remember. This flowchart is very, very important. I'll tell you the importance now. For a hemophilia, I am going to treat with factor replacement. Yes. If you replace factors here, will it be useful? It will be destroyed faster because I'm having autoantibody. Here, my primary role is immunosuppression. There, my primary treatment is factor replacement, right? So I have two different treatment modalities. That's why this is very, very important. Whenever you have an isolated APTT prolongation, please do a mixing study. Only then diagnose with this hemophilia or an inhibitors of factor, right? I hope it's clear, right? That's my second scenario, isolated APTT prolongation. Okay, next. When I have both PT and APTT elevated, possibilities. Normal thrombin time, normal platelet count, possibilities. Any possibility which comes to your mind? Nothing? The simple one. Can it be again liver failure? It definitely can be liver failure, right? It definitely can be liver failure. Any advanced liver failure, almost most of the clotting factors are produced by the liver only. So advanced liver failure will definitely have this. Or can it be a common pathway defect? Can be a common pathway defect. If it's a common pathway defect, also I can have this common pathway defect above the thrombin levels, right? It can be there. If my factor 10 is gone, both of them will be elevated. Factor 5 is gone, both of them will be elevated, right? Will be elevated, obviously, right? So a liver failure or a common pathway defect. Vitamin K also will have the same problem. Warfarin can have the same problem, right? Warfarin overdose can have the same troubles, right? So these are like a combination of both, right? Next, I want you to answer this. Let's see who can answer this. I told you initially itself what does APTT, PT, and thrombin time mean, right? So I have a patient with elevated PT, elevated APTT, elevated thrombin time, but normal platelet count. What's your diagnosis? Thrombin time assays whom? I told you it assays fibrinogen, right? So here all three are elevated. Platelet count alone is normal. So this is afibrinogenemia or dysfibrinogenemia, right? That's very, very important. It's one of the important differential diagnosis. I'll tell you why. Because I have very close DD. I'll go to the next slide. I'll come back to this. Elevated PT, elevated APTT, elevated thrombin time, reduced platelet count. Diksha, DIC I won't take for the previous one. The only difference between this and the previous one is here I have a normal platelet count. Here I have a reduced platelet count, which will be fitting into DIC. Reduced platelet or normal platelet? Definitely reduced platelet, right? Because DIC is consumption coagulopathy, which will consume both clotting factors and platelets, right? So that's the difference here. If it's reduced platelet count, think of DIC. If there's normal platelet count, think of afibrinogenemia or dysfibrinogenemia, right? That's the main difference here. I hope you understand the difference. And if it's DIC, I don't do this. I test with D-dimer. Few things which COVID taught us, one of them is D-dimer, right? So D-dimer is the most specific test for DIC, or in other words, specific test for clot formation, that's all. And FDP is a sensitive test. We never used FDP in case of COVID. We'll do D-dimer only. The entire country has labs have D-dimer now. Again, thanks to COVID. Two of the things which gave good, and amongst the multiple hazards it gave is one of these. Most of the hospitals are equipped with tests for D-dimer. Previous then I had FDP. Now everyone is doing D-dimer, right? So D-dimer is specific, and if that's enough for me to learn it, FDP is a sensitive test. I'm not going to do that fine. Okay. So these are the different ways of your clotting cascade, right? Okay. Just give me a second. Shall I skip this question? Because this question is a very simple question. Rapid assessment of coagulation is done by thromboelastography. I'm just going to skip through it because I want to discuss the next question, which I feel is much more important for us. Okay, tell me this. I'll tell you the reason for discussing this question. It's an X-linked dominant disorder from the below given condition. I'm discussing not for the X-linked dominant. I'm discussing a way to reduce memory remembering this dominant and recessive things, right? X-linked dominant is simple. I'm sure you know this. It's Rett syndrome. Rett syndrome is X-linked dominant, obviously. We have very few X-linked dominant disorders, right? My goal here is to make sure you can reduce the memory on these two things. Remember this. Whenever you have a dominant disorder, most of the cancer syndromes are dominant disorder. Take any cancer syndrome. There's one exception, Men syndrome. Men syndrome is most of the cancer syndromes are dominant only. Your von Hippel-Lindau, neurofibromatosis, familial adenovirus polyposis, Peutz-Jeghers, everything is dominant. Remember that. Second, anything with criteria for diagnosis dominant. What do I mean by that is your Marfan syndrome. They have Gens criteria for diagnosis, dominant disorder. Anything with that is dominant disorder. Anything with criteria for diagnosis, not symptom for diagnosis, dominant disorder. Autosomal dominant or X-linked dominant. Anything with structural protein is dominant disorder. Marfan is a protein, fibrillin, structural protein. Collagen, Ehlers-Danlos loss, dominant. I do have recessive also. I'll tell you why recessive also very soon. Osteogenesis imperfecta, dominant. Again, structural protein. Anything which presents later in life is dominant disorder. The simplest example is ADPKD, dominant later in life. Hereditary spherocytosis, dominant later in life. Von Willebrand disease, dominant later in life. They will not be present at birth. So these are classical rules of dominant disorder. Never forget this. And I have few rules for recessive disorders also. Inborn errors of metabolism will be recessive. I'm not saying autosomal recessive, any recessive, autosomal or X-linked. Phenylketonuria, galactosemia, tyrosinemia, alkaptonuria, everything is recessive. Any inborn error of metabolism is recessive. Any enzyme defect is recessive. Anything with a trait, sickle cell anemia, trait, thalassemia, trait is recessive. Anything which presents early in life is recessive. Remember this thumb rule. The reason for remembering this thumb rule is it will reduce the burden on memory. That's all. I'm not saying if you remember this, you will be able to diagnose every syndrome which is dominant or recessive, but it will definitely reduce the burden, right? Okay, and anything will be recessive only, right? Now let's look at the tables given in Robbins. With these rules, if I'm able to solve a Robbins table, apply the rule again whenever you see dominant recessive disorder, you'll be able to solve most of them, right? This is a table for dominant disorder given in Robbins. Tumor, ADPKD, presence later in life, tumor, later in life, structural protein, structural protein, structural protein, structural protein. All of them are dominant disorders. You can fill up the tables. Just 4 rules. Cancer syndromes, anything with criteria, structural protein presenting later in life. That's enough for me to learn. Most, like 90% of the dominant disorder will come into this only. And if I can remember 90%, I'm not going to go in search of the rest 10%. Let's finish this, then let's go to the 10%. This is a table for autosomal recessive disorder in Robbins. Presents early in life. You see them in children, like cystic fibrosis. Inborn error. Enzymes. This again, elastase enzyme. Presents early in life, children. Inborn error. Trait, enzyme. Almost everything in your Robbins table can be solved with the same 4 rule. Inborn error of metabolism, presence early in life, enzyme defect, and as a trait. You can diagnose everything, right? So this is enough for me to solve quite a few things with autosomal dominant or recessive disorder. Because see, I feel that to remember autosomal recessive disorder, I should not have a mnemonic of A, B, C, D, E, F, G, H. It hurts. You guys are future of medicine, right? You guys are the future of medicine. You will be the future of medicine, good or bad, right? I want you to become the best. These are Mendel's rules, not my rules. Mendel taught us this, so I'm going to teach you whatever Mendel taught, right? So that over the period of time, you don't rely much on memory, you rely more on logic. Future of medicine will be amazing. And I'm promising you, and I'm telling you with so much confidence, you guys are definitely smarter than any of our teachers here. I have to just pass on the knowledge what my seniors gave me. I will do that. You will make it even more amazing, right? So that's it for today. I am just signing off for now. If you have any doubts, do let me know. I will ask them to definitely remove the slow time in the coming session, so that slow mode in the coming session, so that you can comment. And I believe that commenting makes the class more interactive and also makes you to learn from your errors, right? If you have any doubts, you can ping me in my Telegram group or Instagram or in PW Meded's Telegram group. There's a group for PW Meded as well, right? So let's learn more together, and hopefully many of you guys ace INI-CET and come out in flying colors, fine? Thank you for your time, guys. My time is up. So if you're not had dinner, please go and have dinner and sleep early. Thank you. Bye bye. Thank you, Han. Thank you, Arun. Thank you, Diksha. Thank you, everyone. Bye bye. I'll give the PDF in some time in the Telegram group. Fine.